Hi, everybody. If you don't know me, my name's Kinsey Medina, and this is my project. Let me get it started. So the topic I chose for my research proposal was effective interventions for treating childhood apraxia of speech. You may ask yourself, if you're not a speech language pathologist, what is childhood apraxia of speech? Well, let me tell you. Childhood apraxia of speech, CAS, it's a motor speech disorder that causes the person who's inflicted with it, it causes their brain to have problems coordinating, so planning it up here, and executing, so producing it, the appropriate, basically, movements they need to make to produce a speech sound. So we call them oral and articulatory movements. So it's basically just a coordinating and executing issue. It causes variable and inconsistent productions, even from trial to trial. So say mama, and they may say baba, and then may say mana, two completely different productions, even right after each other. It often makes them really hard to understand, very unintelligible, and it's difficult for them to complete. So, understanding what childhood apraxia of speech is, here is the purpose of the study that I chose. So, the purpose of this study is to examine the effects of 3 common treatments and how they affect speech sound production and accuracy when administered during speech therapy. So, I chose 3 common treatments that are usually used for treating childhood apraxia of speech, and I'm basically analyzing those and determining, is there one that's more effective? Is there one that's more effective in a different situation? Or are they all pretty good across the board? I specifically chose ages 3 through 12 because that's whenever CAS is most prevalent. I wrote them right here because they're kind of a lot of big words. The 3 treatment strategies I chose to examine are dynamic temporal tactile cueing, ultrasound biofeedback, and rapid syllable transition treatment. And those will be abbreviated throughout the rest of the PowerPoint. So the main reason I chose this, and the main things that I found through my literature review and my research proposal, is how important this research would be because of the impact that childhood apraxia speech has on the individuals that it affects. So obviously it impacts their communication. So their inability to be able to express themselves to where people can understand them because of those inaccurate speech sound productions, it basically affects what makes us human. We need to be able to communicate our wants, our needs, not just for desirable situations, but for safety reasons. So that can really affect the ability of the child to promote their well-being. Also, that would in turn affect relationships because the communication is lacking. Also academic. So in some of the literature that I read and reviewed, it can have negative effects, childhood apraxia speech can have negative effects on things like phonological awareness, on decoding skills, which in turn affect future reading and literacy skills, and further communication skills through written and oral language. They just tend to have lower academic success. Psychosocial and emotional things also. So in some of the research that I also reviewed, they have lower self-confidence. They're more prone to hyperactivity, so like ADHD, inability to form relationships like we can because of their lack of confidence to speak and their inability to formulate the things necessary to build and maintain a relationship. So the first one, DTTC is what I'm going to call it. So super brief summary. Basically, it promotes neural processing through using auditory and verbal models simultaneously to help shape the child's oral movements. So basically going from where they are producing a certain sound like B, like the B sound, and shaping it to where it needs to go through the use of these 2 different types of stimulation. Ultrasound biofeedback. It provides real-time visual feedback regarding their own productions. So kind of like a recording, and plays it back for them so they can see and hear themselves. And then REST, kind of like what it sounds like. It's rapidly going between syllables to try and promote the fluency between transitioning from one part of a word to another part of a word. So which is most effective? That's the purpose of my research. So to determine this, I chose an embedded mixed methods design. So mixed methods meaning both quantitative and qualitative data will be gathered and analyzed. So I decided to use 15 children ages 3 to 12, like I talked about earlier, of varying severity levels. So they range from just like any other condition within normal limits, mild, moderate, severe. So we would be focusing on mild, moderate, and severe. Um, Using those to gather data, the children will be randomly assigned to intervention groups. And the 3 intervention strategies that I chose and talked about earlier, they'll be administered 2 times a week for 2 weeks each. So the method I chose is first the method of how we would gather data and collect it. First, a baseline of their current level of functioning would be gathered, so to determine their current levels regarding their target sounds and their target goals. How are they performing right now without any intervention? And then the child's productions and performance will be recorded throughout each session. So for those 2 sessions a week for 2 weeks, a data sheet like what a speech language pathologist would use will be used and then analyzed. Their baseline or pre-intervention performance level will then be directly compared to the post-intervention performance levels at the end of each intervention or at the end of each 2 weeks to determine the effectiveness of how that intervention did. After the 6 weeks, because 2 weeks with one, 2 weeks with another, 2 weeks with another. After the 6 weeks of treatment and recording of data, the children's productions and progression of accuracy, which would be the dependent variables regarding their speech goals, will then be analyzed. So since it's a mixed methods design, it has both quantitative and qualitative. The quantitative measures, which I kind of already talked about, it's basically going to be recording the accuracy, precision, and correctness of their speech productions. And I put an example of like what that would be like. So over 10 trials, the child produced the sound in CVC syllables, consonant, vowel, consonant, with 70% accuracy. We would base our gathering of data based upon how they produced their M sound. Gathered through response recording sheets like we use in speech therapy. And then qualitative measures. So the subjective measure, because it's part of this portion of the data collection, it'll be of the child's speech intelligibility. Children with childhood apraxia of speech have severely unintelligible speech. And so this is one really, really good way to determine the effectiveness of the intervention being implemented is it helping their connected speech be better understood at all? And it would be a subjective measure because it would be someone basically determining, did I understand what they said or did I not? A plus or a minus? This would be gathered through interviews with the child's speech therapist, their caregiver, and also through non-participant observational notes. So that would be like me if I was to participate in this and observe the session. This would provide clarity as to if and how the administered intervention, one of those 3, is affecting their spontaneous and generalized speech, as well as is it affecting their confidence in their speech through those notes and interviews. All of this together, the primary intent is to compare these interventions in terms of effectiveness. Is it helping their clarity of speech, their accuracy of speech productions, and their confidence in their speech abilities across all the severity levels? Sampling, I kind of talked about it here. I'm not going to read all of it. I use stratified random sampling. We would find local clinics and get participants that are willing. They would be then separated into subgroups based upon their level of severity to have some kind of control over the intervention groups. And then proportional samples of these children after they were put into their severity subgroups. We would do 5 per group of the final list of participants. And then in those groups from the severity subgroups, then they'd be randomly assigned to a group, each with a different intervention being administered. And then we would analyze the data using a paired t-test to perform their levels of performance pre-intervention and post-intervention. And that will help us show if the implemented intervention promoted improvement, no change, or hopefully not even a decline of skills whenever comparing those. The qualitative data will be collected, like I said earlier, from responses and notes from those surveys and interviews. And then that qualitative data will be used or will be analyzed using that Max QDA software that we've talked about in class. Codes will be assigned to the qualitative measures, and then it'll be able to show us a trend or a correlation to the implemented intervention, how effective it was. The conclusions that I drew was not necessarily from the research I've done thus far. One intervention is not necessarily superior. Further research is warranted. We do want to be able to get this generalizable to children diagnosed with CIS worldwide. That would be the implications of that. It'd be usable by speech language pathologists everywhere. But one conclusion I came to through my literature review more in depth was one may not be superior, but they each had kind of like their key thing, which can be used by speech pathologists to determine, is this child in my caseload matching this description of the child that I found in my review, and therefore should I use REST or DTTC or ultrasound biofeedback or even a different one. So REST I found was good at promoting prosody and connected speech, so like the intonation we use in our connected speech. DTTC was effective in promoting fluency between segmented syllables, so like literally breaking words apart and putting them together and being fluent doing that. And then ultrasound biofeedback was good at promoting self-awareness. Limitations. So obviously there's going to be confounding variables because I made sure to separate these groups originally by their severity, but there's always going to be children who have other things going on, especially since they're children. I just listed some here. Behavioral problems, attention problems, adaptive difficulties. If they're on the spectrum, they're going to have difficulties with that. Other speech language pathologist diagnoses that they've been diagnosed with. Do they have adequate family support? What about their parents' education? What about their race? What about their gender, socioeconomic status, or any other things that are going on that may limit their ability to maintain and generalize the skills being taught to them? Also, another one is small sample size. It is kind of a small sample size, but I thought that we would be able to utilize these quantitative and qualitative data sets to have more of an in-depth look at each of these children by having a smaller sample size. And then kind of like with the confounding variables above, if they've received previous therapy, maybe they have been administered DTTC interventions before, and then we're trying to give them REST. Are they going to be able to learn those new techniques easier or not as well? Don't know. And here are my references. Thank you.